we're going to correct it. So, although I'm not talking about that, we need to bear that in mind. Now, I'm going to talk about binocular instability. In the UK, we call it binocular instability. In America, they call the same condition often fusional vergence dysfunction. It's the same thing. And vergence, as you know, if you think about vergence, one way to think about it for many people is as the resting position. So if somebody's in a completely dark room, or if they're drunk, I tried to get funding to research that and they won't fund me. But if they're drunk in a completely dark room, for most people, the vergence system adopts a resting position where the eyes are pointing at an imaginary object about a metre away. So also the accommodation usually rests there. The tonic accommodation reverts to there. And you can think of convergence as an active process during near vision to take the eyes away from that resting position. And you can think of distance vision as requiring a divergence to take them away from that resting position. And binocular instability is really when their tendency to go back to that resting position is excessive, and their divergence and convergence is not taking their eyes away from that as strongly as it should. So hence fusional vergence dysfunction is quite a good term for it. And it goes back a long time. Eames was one of the first ophthalmologists to research dyslexia, and he talked about fusional deficiencies in dyslexia. Giles, a famous optometrist in the UK, he noted back in 1945 that binocular instability causes word blindness. Gibson, another famous optometrist who did lots of binocular vision work, he noted that binocular instability causes problems with perception of text and numbers. And Bedwell, who was at City University just before I got there, he must have left just before I went there, he researched dyslexia and vision and noted poor binocular control in dyslexia. And then Stein is a physiologist working at Oxford who found poor vergence control in dyslexia. And these are all things, I think, that are describing the same result: binocular instability or fusional vergence dysfunction in dyslexia. And when I did my PhD in dyslexia and vision, we found this result as well. So this was the PhD work that we did. We got a group of dyslexics and a group of controls, and we matched them. We talked about research design earlier this afternoon, didn't we? And we said that you should match them. We matched them carefully for age. We matched them so the IQ, the mean IQ of the two groups was the same. We made sure that both groups had similar opportunity to learn. They were in similar socio-economic groups from the same areas, and so on and so on. And we measured a variety of results. They all had normal visual acuity and refractive error. We found the magno deficit in the dyslexia. I'm going to talk about that tomorrow. But we also found that in the same sample, that the dyslexics had lower fusional reserves, both convergent and divergent. So we found signs of this binocular instability. And they also had a less stable heterophoria, another sign of binocular instability. But they had normal near point of convergence and normal stereoacuity. So this binocular instability is characterized by these two things: an unstable phoria and low fusional reserves.
Excuse me, how do you check the magno deficit?
Yeah, I'll talk about that tomorrow. Yeah, we looked at their ability to perceive flicker and also at their contrast sensitivity, and that was both signs of the magno deficit. But we'll talk. I've got a whole lecture on that tomorrow. So
flicker, mama?
Flicker, yeah.
זה contrast sensitivity. זה אורות דברים שנדלקים ונסגרים.
לא, אבל מה זה בודק?
דיסלקציה.
מה זה מגנו?
one of the things we wanted to do in this study was if we found a visual deficit, we wanted to know whether that was likely to be a cause of their poor reading. So we got them to do a word reading, a number reading task, a bit like the DEM actually, but I think this was before the DEM. Anyway, we got them to do a visual search task that involved reading numbers, scanning numbers, to see whether any visual problem we found was likely to cause poor tracking, if you like. And we found that the difference between groups was very mild, very minor, and wasn't linked to the binocular instability. So we thought that in most cases the binocular instability was not a major cause of the poor reading.
Do they have more phoria than others?
No, same phoria as the others. Yeah. Now this was a study published about the same time, a bit later, study comparing dyslexics and controls, there were some problems with this study. They classed the visual data as pass or fail, but nonetheless they argued that all of these tests were the same in the two groups, apart from the divergent fusion reserves. That was low. So if you like, they found one sign of binocular instability.
Was it the Dunlop test?
Yeah, I'll talk about the Dunlop test tomorrow morning. It's a test that is thought to detect binocular instability, but it's been shown not to be a very good test, so we don't do it anymore, but it's a test of dominance, a type of dominance that's thought to detect binocular instability. So this was another study that found a similar thing. A study in 2010 that found that children with reading disability had normal phoria but low divergent fusional reserves. Another study by Woolberg, Ramsey et al., they found that binocular deficits, they did find some subtle binocular deficits. They thought they were secondary to the phonological deficits. And this was another study that I'll show you a whole slide on now, because this was an interesting study by Quaid and colleagues. More recently, there's been a couple of papers arguing that dyslexics have worse binocular coordination during and after saccades in reading and non-reading tasks. So all of this is pointing towards a subtle binocular instability being associated with dyslexia. And here's another study quite recently arguing that dyslexic children have increased fixation disparity when reading, but not in other tasks. So they again argued that there's something atypical about the binocular vision, that they didn't think it was causally related to the poor reading. Here's the study by Quaid and colleagues. They looked at 50 children with an individual education plan. Now they're in Canada, and in Canada an individual education plan, IEP, is what is given to children who perform badly in class. So they were underachievers. There were some problems with the study. They didn't match the groups for intelligence or for attention, and the control group were not very well selected. They found the IEP group were worse at almost all their tests, but this could be because of the poor matching they had. But the test that really was most convincing in their data, and I have included this study, despite the study's problems, I've included it because they got such a big effect. And this big effect is invergence facility. So they had a flipper here with base in and base out prisms, and they flipped it a bit like you'd do with accommodative flippers, but to measure their vergence facility. And they found that those with a poor education, with the struggling at school, did much worse. These are the red, these are the blue dots of the children who were struggling in class, and their vergence facility is a lot worse on average than the good readers. But interestingly, they showed that the children that had the worst symptoms were those with the worst vergence facility. So this is, I think, an interesting study. Not many people research Virgent's facility, so this needs to be replicated, but it was such a strong effect that I thought it deserved a slide of its own. And there have been a couple of other studies supporting Virgent's facility as being something that's worth looking at. So, recent research, a functional MRI study in 2014 compared normals with dyslexics and with people with an ocular motility disorder. And this study showed that the brain circuitry used for reading is different in dyslexia compared to people with a BV problem. So this did show some subtle differences, but they concluded, therefore, that dyslexia is a neurological disorder unrelated to vision. Now, I have a few problems with this study. I'm not sure that their logic is perfect, but they nonetheless had an interesting approach. This study looked at eye movements in visual search and found they were similar in dyslexics and normal reader, but again they found some signs of binocular instability between and during and after the saccades. This was a paper published a couple of years ago that attracted a lot of attention, and it's a great shame, this paper. It's a great shame because it was a big opportunity. They had a huge sample of 5,800 children where they gathered lots of data, and they looked at those whose reading was more than 2 standard deviations below the mean, and they described them as having severe reading impairment, or SRI. And they found no association between SRI and strabismus, or motor fusion or sensory fusion, or a whole variety of other measures. They did find that more of them had stereo acuity worse than 60 seconds of arc. So they said, we find no evidence that vision-based treatments would be useful for children with reading problems. But there are some big issues with this study. I published a letter to the editor that was published to the journal criticising what they'd done. The first thing they'd done was they hadn't used terribly good tests. So they hadn't chosen very appropriate tests. For example, they hadn't looked at fixation disparity. They hadn't looked at Virgent's facility. They also had done no testing for visual stress, and the worst thing they'd done was, for all of their results, they'd created that crime, in my view. I call it a crime, the crime that I talked about in the presentation on evidence-based practice. Do you remember I said that what is a criminal thing to do is to take a continuous variable and to reduce it to a simple pass or fail, normal or abnormal. And that's exactly what they did. And so they threw away a huge amount of very valuable data, and therefore their study is very much flawed. Even when you look at the very limited results that they got, they showed that 4 of every 5 children with reading impairment had normal ophthalmic function. What does that tell us? Well, it tells us that 1 in 5 children had abnormal optometric function. So, you know, I don't actually have a problem with their results, but they interpreted as saying vision's not relevant to reading. I don't think that's what they showed. I think they showed that most children with poor reading have normal vision according to their criteria, but still many have visual problems. So to summarise binocular instability is characterised by blur, double vision, sometimes seeing distortions on the page, and eye strain and headaches. Binocular instability is detected in the consulting room by low fusional reserves and unstable heterophoria. The best way to look at heterophoria, I think, is to use the Mallet fixation disparity test, because it's a more natural way of looking at binocular vision. It's also useful to measure fusional reserves. Let's start with the Mallet fixation disparity test. And have you've probably all seen this test. Have you all seen the mallet test?
Yes, we learned about it.
It's designed to be fundamentally different to Fourier tests. It's very different to Fourier tests because in the mallet unit there is a good foveal and peripheral fusion lock. The foveal fusion lock are the OXO that are seen by both eyes. The peripheral fusion lock is the text around the test. And only the green strips are seen by each eye. Everything else is seen by both eyes. So because of that, it simulates normal viewing conditions, and therefore it assesses binocular vision under natural conditions. You don't measure the fixation disparity. The test relies on you measuring the aligning prism and the spheres that eliminate any fixation disparity. And it's been shown that the question set is very important. Karania and I showed this, that you need to ask them whether there's any movement of one line. Even a very small, subtle movement of one of the lines is a sign of binocular instability. And I showed you these data earlier, that the test has been shown to have good sensitivity and specificity for detecting symptomatic phoria at near. The test doesn't work so well for distance vision. This was a study that we did where we looked at the degree of prism they need to bring the strips into alignment, and we looked at the number of symptoms they had, the severity of their symptoms. And what we found was that the higher the prism they needed to bring the strips into alignment, the more severe the symptoms were that they had. So that was quite nice. It showed, if you like, a strength effect. You can do the test on the mallet unit. There are now other ways to do the test. You can do the test on an iPad. You can do the test on the new Hoya iGenius computerized testing system.
On the iPad you have to order it?
On the iPad you have to use red-green. Yeah.
Oh, right.
To do the test, you really want to do it as naturally as possible. So it's best not to use a phoropter, because you want a full field of view. It's best to use trial lenses. Handheld loose prisms are best. You're finding the minimum prism to bring the strips into alignment, and you should renormalize the binocular vision between the prisms. I personally think the prism diopter steps that are best to use are 0.5, 1, 2 and 4. Now, if you could bring the strips into alignment with 0.5, that's a normal result. So that's good news. But it's useful to do that so that you know if they need more than 0.5. The other test that's very useful to do is fusional reserves. They can be measured with a prism bar, with a phoropter. They can be measured with a stereoscope, with rotary prisms and a phoropter, or I think the most common method these days is to use a prism bar. Now these are things, we've got a brief workshop tomorrow. I think you're probably familiar with most of these tests. If you're not, then we've got a workshop. We can go over any of these tests that you want to go over tomorrow. With younger children, of my daughter when she was tiny, and you can use a 20 base out just to check that they have some degree of convergence. So people sometimes say, what is the difference between binocular instability and decompensated phoria? And this table tries to summarize it. A patient with binocular instability may have a phoria, but they may not. You get some patients who have a zero phoria, but they have an instability. So when they look at the mallet unit targets, they see a movement of those. If you do the Mallet's wing test, you say, which number does the arrow point at? And they say 0, 2, 3, 2, 3.
Yeah.
On average, it's 0, but it's moving more than it should move. The fusional reserves in binocular instability will be low, both convergent and divergent, whereas in decompensated Fourier, it's just the reserve that opposes the Fourier that tends to be low. And the interesting thing is, binocular instability is correlated with dyslexia from all of the research that I just talked about, whereas decompensated Fourier doesn't seem to be correlated with dyslexia.
Excuse me, decompensated Fourier, it means that it's a Fourier?
It means that it's a Fourier that is producing problems. So a Fourier that the patient is having trouble compensating for. So classically it's a Fourier that is causing symptoms, either because the fusional reserves are so poor, or because the Fourier is so big that the fusional reserves can't overcome it. Or occasionally it can decompensate because their sensory fusion is poor. But in decompensated Fouriers, where the main problem is the Fourier that they can't compensate for, whereas in binocular instability there may be no Fourier that's there.
But the reserves are small in the binocular instability.
Usually the Fourier is small, yeah.
No, the reserve.
Yeah, the reserves. Sorry, yes, the reserves are small. Yeah,
but
in both
also
directions.
there, the reserves are small.
Yeah, but in binocular instability, both reserves are low, whereas in decompensated Fourier, only the reserve that opposes the Fourier is low.
Ah, the other side may be big.
Yeah. Okay. Classically, in decompensated isofourier, the divergent fusional reserves are the problem, and the convergent fusional reserves are really big. And in convergence, in divergence excess, exophoria, their divergent fusional reserves will be huge, absolutely huge. And if we think about binocular instability, the classic way of looking at binocular vision is to compare with norms. Is to say that if V is the fusional reserve that opposes the Fourier, and N is the normal value of the fusional reserves, that either the fusional reserve should exceed the norm, you all know that approach, or Sheard's criterion, which is useful for diagnosing decompensated exophoria. Sheard said that the fusional reserve that opposes the Fourier, so the convergent fusional reserve, should be at least twice the Fourier. That's Sheard's criterion. I would argue that actually we need to think about it differently. And the reason I think we need to think about it differently is because during normal saccades, most of us have vergence errors that happen at some point, particularly when you're making a big saccade, like when your eyes are moving to the beginning of the next line, or in Hebrew, sorry, moving to the beginning of the next line that way. And when you make these big saccades, often there can be a vergence error that can occur. And if that vergence error occurs, it can be as much as 20 minutes of R. That's a lot. It's a big vergence error. So even if you have a patient with zero Fourier, they're going to need some fusional reserves to help them overcome any vergence errors that occur. So I think that actually the sort of formula that we should be looking at when we say, are the fusional reserves adequate, is not just that they should exceed a minimum or a multiplier of the Fourier, but rather that the fusional reserve should be more than a multiplier of the Fourier plus a constant. So for somebody with a Fourier of 0, the fusional reserve should be more than the minimum constant, and for somebody with a Fourier, the fusional reserve that opposes that Fourier should be bigger still. That's, I think, the sort of analysis that's probably likely to apply. Now, we talked in the evidence-based presentation about the problem of doing too many tests. That if you do too many tests, eventually your patient is bound to fail one of them. So when we combine tests, I think we need to do it in an intelligent way. And this is something that I've tried to be doing for many years now. It was in my book, Pickrell's Binocular Vision Anomalies. It was in the 3rd edition of this that we first suggested this, and that was published in the 1990s, I think. And what we argued was that when you're trying to diagnose binocular instability or decompensated phoria, you can combine tests together to get a score. And this, if you like, is what you probably do in your clinic, in your head, but we're trying to put it together into a scoring system. So what you do is you say, do they have symptoms that are suggesting a binocular vision problem? And if they have, you give them a score depending on the severity of their symptoms. If there's a cover test showing a phoria, they get a score of 1. If the cover test shows bad recovery for the phoria, they get a score of 2. If it's borderline, 1. If they have an associated phoria, sometimes called an aligning prism on the mallet unit, then they get a score of 2 if it's significant. And if it's unstable, they get a score of 1. And then you add up their score so far, and some of your patients will have such a high score that they're obviously abnormal. You don't need to do more tests. Some of them will have such a low score that they're obviously normal, and you don't need to do more tests. For the ones where their score is borderline, then you can do additional tests like Sheard's criterion, Percival's criterion, and the amplitude of the versions to look for binocular instability. So this is a sort of algorithm to help in the clinic make a diagnosis of binocular instability or decompensated phoria.
How do you see the foveal suppression in the mallet test?
Yes, you can. Yeah,
How?
there is a test of foveal suppression there, a test where there are some polarised letters that the child looks at, and those polarised letters, some are seen by both eyes, some by the right eye, some by the left eye, and that is the foveal suppression test in that test. You could also do it with some stereo tests, like the Randot, have a test of foveal suppression as well. So, I think we'll finish after this slide, summarise binocular instability. Binocular instability is characterised by low fusion reserves, unstable phoria. And when you look at the prevalence of binocular instability, the data that we got in this research in 1994, if you pick a criterion that would find binocular instability in 5% of good readers, that same criterion finds it in 3 times as many dyslexics, 15% of dyslexics. But that means that 85% of dyslexics don't have it. And I think that is about right. So most children that come to see me with dyslexia, I don't find binocular instability. But sometimes it's there, and if it's there,